Okay, so welcome back. I don't know if Roland is with us at the moment, but we're back here in Ghent. And we're just waiting for the patient to be ready for the next case. But I was having an interesting conversation, which I think is actually quite interesting for everybody with Fleur. So I don't know if you want to maybe pose that question I think it's very interesting for everyone to get into that.
Yes, I was just asking. I'm a trainee, and most of the time I perform a gastroscopy without sedation or with a little bit sedation with midazolam. And sometimes, yeah, it's the first diagnosis of a Barrett. And then, yeah, I take time to look at the Barrett lesion and to search for visible lesions. But when I see the gastroscopies we performed earlier this day, yeah, I think I would definitely miss the septal dysplasia lesions just because the tolerance of the gastroscopy wasn't that good. So for me, the time to say, yeah, we want to reschedule the gastroscopy under anesthesia is difficult. So I was wondering, yeah, what the answer was.
Well, so I think that there is no answer, unfortunately, but what your point is very important. And I started by saying to you, well, I think what we're talking about, and let's start to show some stuff. What we're talking about is this kind of thing, right? This, like, how do you possibly obtain an image like this when you are having someone writhing around and everything else, right? It's a great question. So, of course, there is the idea that a lot of the gastroscopy we do is normal and will be normal, and we're overdoing it. So it is how to exclude those patients from this discussion. And I think we already said that a nice way to do that is to think about the pathologies, right? The pathologies which cause the main number of the pre-malignant conditions are the ones where patients getting cancer after a normal in inverted commas gastroscopy. There's also probably the answer that you should, because there is tolerance level for a patient, and if you've got no resource to repeat this procedure, then probably you should be focusing initially at the bottom of the esophagus, the retroflexion, and the top of the stomach, because that is where the pathologies are. So the tolerance decreases, I guess, as the procedure goes on, and therefore probably I think I support very much the Nigel and Roland's drive to inspect the esophagus first, then the stomach and the proximal stomach before the distal stomach, and then go on from there. I think that's another part of that. And then my final part of that is the tolerance of the procedure and who is going to tolerate gastroscopy well or not. So we have this, didn't really introduce it today, but I did introduce it yesterday. I will briefly show you what I mean. So it's a tool to assess the quality of gastroscopy. It is called this. So its name is GIEQs, Gastroscopy Assessment Tool. We forgot the X. And then it goes over global skills, how you prepare the scope, how you put it in, how you withdraw. And actually, we introduced the concept of a weighted score. Exactly why? Because of what you're saying is that there are some published parameters which make tolerance of gastroscopy worse, right? And so I think if we go no here,